Well, good afternoon, everyone. I'm Russell Roybal, Chief Advancement Officer at San Francisco AIDS Foundation, and I want to welcome you to another edition of the TogetheRide In Conversation series. Today, we're going to be talking about harm reduction and preventing HIV in all communities. So I want to welcome you, and I want to give you a couple of housekeeping items right up front. If you would like to access closed captioning, you can scan the QR code in the top corner of the screen, and we'll also be placing the link in the chat as well. And as always, if you have questions for our panelists today, please put them in the chat on Facebook Live or on Twitch, and we will try to get to all of them at the end of the show. And now I want to welcome our panelists today to TogetheRide In Conversation. First up is Laura Thomas. Laura Thomas is the Director of Harm Reduction Policy for the San Francisco AIDS Foundation, where she is leading the work on drug user health, harm reduction, and access to treatment, with a focus on efforts to open supervised consumption services in San Francisco. She has been advocating on HIV and public health issues in San Francisco for over 30 years, since becoming involved in AIDS activism through ACT UP San Francisco. Welcome, Laura. Also with us today is Ro Giuliano. Ro is Director of Syringe Access Services, Programs, and Operations at San Francisco AIDS Foundation. SFAF SAS is home to our innovative Harm Reduction Center, a warm and welcoming place where people who use drugs can access safe injection equipment, overdose education, and response training, and an HCV treatment program, which provides on-site HCV treatment and medical care to people who inject drugs. Ro has worked in the harm reduction movement for over 20 years. Welcome, Ro. And finally, Sarah McCusker. Sarah is a licensed clinical social worker and addiction recovery services therapist at the Los Angeles LGBT Center. Sarah is a graduate of the USC School of Social Work, and prior to her work at the Los Angeles LGBT Center, worked with the community in New York and New Orleans. Welcome, Sarah. Hi, everybody. Welcome. Thank you for joining us today. So excited to have this conversation because I think whenever I get to talk about this work, it always leaves me wanting to do more. And in fact, when I first started at San Francisco AIDS Foundation, one of the first places I went was to the Harm Reduction Center. It was right before I started. I hadn't got to see it during my interview process, and a staff member took me over, and I was there for 20 minutes. And in that 20 minutes, it is the entire reason why I wanted to come to San Francisco and to work at San Francisco AIDS Foundation, because the work there was so amazing to witness. And I had so much and still have so much admiration for my colleagues who work at the Harm Reduction Center and work in our syringe access program. So excited to talk to you about all of that today. But first, we have a little video to show that will give us some information about the topic today, and then we'll dive into our conversation. So let's see the video.
Look, you're smart, you're cool, and you don't want to die, so you do things to reduce the harm of the risks you take. That's called harm reduction. It's all around us.
Taxi!
Harm reduction is common sense. It stops people from being injured and dying from things that are preventable. It saves lives, it saves money. It's smart. Here's a fact. Last year, 47,000 people died of drug overdoses in the United States. Because you're smart, you know these deaths are preventable. But here's something you may not know. Some kinds of prevention don't work.
Just say no. Who taught you how to do this? Any questions?
It's time to stop the drugs.
We've tried all these things, and still the number of people dying of overdoses continues to rise. But remember, you're smart. And because you're smart, you want to stop these preventable deaths. Do you know what is clinically proven to work? Harm reduction. You remember that, right?
Taxi.
Harm reduction works for people who use drugs. It knows that people aren't perfect, but they deserve every opportunity to be as safe as possible. It encourages people to get educated and connected with healthcare. Harm reduction provides access to naloxone, the drug that reverses overdoses. It provides people with sterile supplies to prevent the spread of HIV and viral hepatitis. And when harm reduction is implemented in its most effective form, it gives people who use drugs access to supervised use sites in order to provide life-saving interventions in the event of an overdose. In 102 supervised use sites worldwide, there's yet to be a single fatal overdose. With more than 47,000 overdose deaths each year, what are you waiting for? Support safer, healthier communities by supporting supervised use sites in your city today. Learn more at www.harmreductionactioncenter.org.
What a great video. I love watching that video. I've seen it a dozen times and I could watch it a dozen more. So a great video from the Harm Reduction Action Center in Denver at San Francisco AIDS Foundation. We actually use that video as a primer for our board staff and volunteers on harm reduction. But while the video is great, there's also more context that we want to share with you. So Laura, could you build on what we just saw in the video and give us a little more informed understanding of harm reduction? One of the things that we talked about in our prep call was how harm reduction is really a continuum. Could you also touch on that?
Yeah, first I want to spend a minute because I've seen that video and I love it. What strikes me is that that video was made, the number of overdose deaths have doubled in the U.S. And so they said 47,000 people died last year. It was closer to 90,000 people who died in the U.S. of an overdose. And here in San Francisco, we had more drug overdose deaths last year than we had COVID deaths. So that gives you some sense of where the epidemic is going. But yes, harm reduction is a set of common sense approaches that we all use in daily life, like seatbelts and bike helmets. And it's also it's a public health philosophy. It's a social justice movement, ensuring that people who use drugs have the tools and the context that they need to live healthier, safer lives. And sometimes we get into this place where harm reduction pitted against recovery services or other types of substance use disorder treatment programs. And that's not really how they operate in real life. And that's not how we provide services here at the San Francisco AIDS Foundation. We see the full continuum from our street outreach to more intensive counseling services. And for us, it's about helping people, A, stay alive, B, figure out what their health goals are, and give them the tools and the skills and the support that they need to achieve that. So for many people, that may look like abstinence. That's where they want to be. That's where they need to be in order to keep themselves and their families as safe as possible and achieve their health goals and other goals. And for other people, it may just be about, getting the syringes or the safe smoking equipment so that they don't acquire HIV, they don't acquire hepatitis C, they don't overdose. But it's really should be seen as all part of the same thing. And in fact, many people who have gone to recovery through our programs, through other programs, they started with harm reduction. That for them, that was the first place. The syringe access programs, for example, were the first place where they felt welcome as their whole person, and were able to build on that feeling of community and belonging and feeling welcome somewhere, to then take the steps that they needed to take in order to achieve recovery as they wanted to achieve it. So that's a bit about how it fits into a broader continuum, especially here at the San Francisco institution.
Thank you, Laura. While harm reduction can really apply to many things, including a range of actions and services that Laura just touched on, we're focusing this conversation on the bulk of what Laura just talked about, which is substance user health and the application of a harm reduction philosophy. So Sarah, could you tell us a little bit about the services that the Los Angeles LGBT Center provides around substance user health and its intersection with HIV care?
Yes, thank you. And Laura, thank you for addressing that. Often there is a misconception that recovery and harm reduction are not actually working together. They are working together. And at the center in LA, we have several we believe in different stages of change. Some people are curious about recovery services. And so for those folks, we offer some more harm reduction based services. And that can look like, for instance, we have crystal meth services where for some clients that involves harm reduction, and for some clients they can also go to an abstinence-based program. We've seen the comorbidity of HIV and drug use, as well as drinking, that this just increases the risk for risky behavior, for increased substance abuse. And so by offering wraparound care at the center, where we can address the goals of maintaining physical health, mental health, and addressing recovery issues in a broader sense, so that they're tackling that through group therapy, individual therapy, needle exchange. We want to give people the opportunity to be met where their level of willingness is really what we're trying to do, instead of a prescribed answer for the same answer for everyone.
Thank you, Sarah. And Ro, what about the work at San Francisco AIDS Foundation?
Yeah, I guess I could speak a little bit about our harm reduction center and our mobile sites. And just to get an overview, right, we have a brick and mortar harm reduction center that operates 6 days a week. And that is in the South of Market neighborhood of San Francisco. And at our harm reduction center, we offer everything from access to syringes, other safe injection equipment, safer smoking supplies, naloxone, health education, counseling sessions. You know, during COVID, we had to scale back a bit, where we just became a place where you could come and get the supplies you needed, and you could also access HIV testing, hepatitis C testing, full sexual health screenings, and we offer on-site hepatitis C treatment. And so, you know, prior to COVID, what it looked like is we also had like a lounge drop-in space. So folks could come in and get supplies, or they could just come in and hang out and have a place to talk to someone. So wherever they were at, they could, you know, maybe they didn't want to do anything but sit there for an hour, so they can do that too. So just meeting folks wherever they are in their experience. The majority of folks that do come into our harm reduction center are either living in the surrounding single room occupancy hotels or are experiencing homelessness. And so just having that community space is often super important. You know, and we didn't miss a beat during COVID. During 2020, we had over 58,000 encounters across our services. We gave out over 36,000 doses of Narcan. Our community reported close to 4,000 overdose reversals. In addition to our harm reduction center, we have 5 mobile sites that happen each weeknight in various neighborhoods in San Francisco. We do over 20 hours of outreach a week. Yeah, we have a lot going on. You know, the harm reduction center is a pretty exciting space. And I think, you know, one of the things that's super important, you know, our staff often are folks of lived experience and are really super understanding around the community and what the community needs. Our Hep C treatment program also can link folks to HIV care, and we have an on-site locker program, which is pretty innovative and amazing. So folks that are experiencing homelessness can store their Hep C meds and their HIV meds on site. So if they get displaced by police sweeps or their things stolen, their meds aren't in the mix. And so we really try to be that anchor for folks in the community.
Ro, for folks who may not be as familiar with what Narcan is, can you just do a couple sentences on what Narcan is and how it prevents overdose?
Sure. So Narcan or naloxone is a medication that reverses the effects of an opiate. And so when we say opiate, that could be heroin, that could be oxy, that could be fentanyl. And so it basically will go in there and kick the opiates out of the receptor sites and reverse the overdose for that moment. Yeah, that's kind of a quick answer. Folks can administer it via injection or via like a nasal spray. It looks like almost like Flonase or some sort of allergy medicine. And so you can just think of it like an EpiPen for an overdose situation, but it only works with opiates, right? So if there's something else going on, it's not going to affect that, but it can reverse an overdose. And so there's lots that go into supporting someone through that process, but that's the quick and dirty of what Narcan is.
Great, thank you for that. And if folks are looking for ways that they can contribute in their community, you can get trained on how to administer Narcan. The San Francisco Space Foundation has a program of that. I'm sure that there is a similar program at the center or a partner of the centers. I live in the South of Market neighborhood, and I went through a training and carried Narcan with me, with nasal injectors with me when I'm out walking around. So it's something easy that you can learn to do and really make a huge impact in the community that you live in. So we talked about kind of what's available, but let's talk about the barriers that exist to delivering the services, Sarah, that you talked about and Ro that you talked about, and how is each of our organizations addressing those barriers? Sarah, why don't we start with you?
Sure. Well, one of the major barriers, I guess it's hard to talk about anything without talking about COVID. So specifically right now has been the lack of access to services in person. A lot of the harm reduction services that we provide are group services that we've had to make arrangements over video and telephone. That presents its own kind of barriers. So I just want to address that we've seen an increase in the number of folks seeking services and an increase in people's availability to make it to sessions, to make it to group. So I'll be curious to see what that looks like going forward, because transportation has always been a barrier to resources, especially in a city as big as Los Angeles. And so the way that we're addressing that is we're expanding locations. So that's one way to do that, and making our locations in neighborhoods and areas that are higher needs. As well, it's cost services. And so that's what we know about nonprofits, and that's how they can be is assisting folks that without insurance can access these resources through either free services, which most of our HIV testing, PrEP, all of those things, free services, and then sliding scale for different types of addiction services, therapy, inpatient, intensive services that are also can be accessed in other places that can be really expensive. So the barriers are finances, transportation, a lot of the barriers to wellness and health in the larger sense in this country are a lot of the same ones that we face at the center.
Thank you, Sarah. And as all of you watching know, that your funds that you raise through TogetheRide or through AIDS Life Cycle are supporting this important and really life-saving work at both the Los Angeles LGBT Center and the San Francisco AIDS Foundation. But Ro, what are some of the barriers that in San Francisco, and how is the foundation addressing those?
Yeah, I think, a lot of times when we think about barriers, I think of when services are provided that, are too high threshold or that aren't really taking into consideration the needs of folks, the needs of people who use drugs, the needs of people who are experiencing homelessness. So the way in which we break down barriers is just, we're always in the mix, right? Like, we go out into the community to provide our services. We, our harm reduction center is located right where a pretty high traffic area, right, where lots of folks who use drugs are already hanging out. We go into various neighborhoods. We try to have our staff reflect the community that we serve. A lot of folks on our team are folks who have lived experience. And so just when you are building those relationships with folks, just constantly recognizing that the individual is, the expert on their body and their experience, and making it that warm and welcoming space. I think a lot of times the barriers can be staff and, folks who are gatekeepers of services can really become a barrier themselves when they're not dismantling stigma and when they are not really centering people who use drugs and in all of that they do. And so I think that that's something for sure that's important.
Yeah, I mean, I think that one of the things that I have so much admiration for my colleagues that work at the Harm Reduction Center is really like the radical hospitality and radical welcome that folks practice there, because it is such a welcoming, inviting space for people to just come and be who they are. And I mean, there are so many parallels, I think, around, right, the integrity and autonomy that we have over our own bodies, and so many parallels to like all the movements that our organizations represent. Laura, you wanted to give a plug for Narcan.
Just to some of the work that we've done on the policy front, the AIDS Foundation has helped make naloxone more accessible in California. So any pharmacist in California can dispense naloxone to you without a prescription. It's as close as we could come to getting it over the counter without changing federal regulations. So, Walgreens, CVS, places like that, you should be able to get it there, although you'll have to pay for it. But they'll give you a quick training on how to use it, and then you'll be able to carry it. I think that's one of the most important things that people in the community can do if you're concerned about overdose, is to get naloxone and carry it. And encourage other people around you to carry it, because you never know when it might be needed. If you're in San Francisco, the DPH pharmacy at 1380 Howard will dispense it to you for free and give you a quick training on it. But as Rose said, it's really easy to use. So I encourage people to, it's one of the most concrete things you can do. It's sort of like getting CPR training. You can, except it's a lot easier and shorter than CPR training, is just to get naloxone and carry it. Thanks.
Thanks, Laura. And so, Laura, San Francisco AIDS Foundation has been part of a coalition of groups looking to bring safe consumption spaces into California for the last several years. Can you tell us where we're at with legislation? Well, maybe first tell us what is a safe consumption space, and then tell us where we are with legislation, why we support it, and why these spaces are a critical piece of our organization's strategic plan.
Yeah, well, they were referenced and described a bit in the video that you saw at the beginning, but it's a place where people with people bring in the illicit substances that they want to consume, and are given a safe, clean, sterile location in which to do those substances with trained staff, essentially the same type of staff as we have at our syringe access program now. People who can recognize the signs of an overdose, who know how to intervene. They're trained in responding and reversing an overdose or anything else that might go on for folks. And then people are given a place where they can sit for a while, recover from the substances they've just used, and it's taking this radical hospitality that Russell referred to and taking it a step further. Right now, what we do with our syringe access programs is, we give people the syringes and the other equipment that they need, and then we say, okay, now go out and use in the alley or your hotel room or your home. This takes that one step further and says, and now you're welcome to use your substances here. As you heard in the video, there are now, I think close to 200 of these sites around the world, but there are no authorized sites in the US. And as we've watched our overdose numbers climb, as we've watched these HIV outbreaks and hepatitis C outbreaks related to not having access to sterile syringes, I think we've all felt compelled to push for the next step, which is supervised consumption services. And so it's consistent with our goals around getting to zero with HIV. It's consistent with our goals around eliminating hepatitis C. It's consistent with our goals of reducing overdose deaths and keeping people alive and helping them to access services. So it's important to the San Francisco AIDS Foundation, and as Russell said, we're in the statewide coalition with the main substance use disorder treatment providers in the state, the National Harm Reduction Coalition, Drug Policy Alliance. And we've been pushing for many years on this. This year, the fourth bill is moving through the legislature. This time it's authored by our own State Senator Scott Wiener from here in San Francisco. And it's SB 57, State Bill 57. And just last week, it passed the state Senate on a vote of 21-11. So we're moving forward to the Assembly now, and we'll need to get it through the Assembly and get it to Governor Newsom's desk. But this issue has never lost a vote in the legislature. We got AB 186 to then Governor Brown's desk, which he vetoed, but we're going to be pushing hard on Governor Newsom to do something different and support this. There's, more and more states and cities around the country are looking at this as they deal with this overdose crisis. So it's in line with, with our mission around, ensuring that people who use drugs, that we're able to eliminate the stigma related to drug use, that we're able to eliminate people's health risks, that we're able to eliminate the racial disparities related to overdose and HIV and hepatitis C. So, I came to the San Francisco AIDS Foundation in large part to work on this particular issue, and I'm really proud to be here at the AIDS Foundation as one of the national leaders on this issue. And I'm grateful to all the support from TogetheRide and AIDS Life Cycle in helping to make this possible. But I'm happy to answer any questions people have about this issue and or anything else along these lines.
Great. So if anyone has any questions, please feel free to put them in the chat and we'll get them answered. In fact, we have a couple of questions that have come in already. So let me read the first one and then decide who wants to take it. The first is on Facebook. I hear a lot in the news about the rise in overdose deaths across the country. What's driving the increase in overdoses? And is there anything community members can be doing to help? Laura, you mentioned at the beginning that that video it's not even that old, but that the number has increased so much. And then in San Francisco, there have been more deaths related to overdoses than to COVID. And you talked about Narcan, but for any of you, what are driving those increases? And then are there other things that folks in the community can do to help? Who wants to take that or go first?
I mean, I'm happy. So go for it, Ro.
You sure? Okay. Like here in San Francisco, right, 2 people a day are dying of overdose. And I think there's a lot of different factors that come into play, right? When we look at poverty, when we look at, people experiencing homelessness, and when we look at isolation. And I think isolation is a key thing to look at. And that's why when we talk about safe consumption sites, it assists in that way, right? And so when folks get trained in Narcan, when community members have Narcan, and they could reverse overdoses within their own community, but someone has to be there. So I think isolation and reducing isolation is a big part of that. I also think our drug supply has changed. And so, you have a market in San Francisco that was formerly tar heroin and now is dominated by a synthetic opiate like fentanyl, and sometimes that supply can be unstable. And in saying this, I don't want to demonize fentanyl as a drug. It's just a substance, right? And so, just folks navigating a much stronger drug in addition to all these other compounding factors, I think drive these numbers up. Yeah, I could kind of go off forever, but I'll hand it over to Laura.
And on the policy front, it's a lot of the structural stuff. Drug use is criminalized, it's stigmatized, and one of the most significant things we need to do is to decriminalize drug use and move it out of the criminal justice system, which does not have any good tools for addressing this, and move it into the public health system, which does have better tools for addressing substance use disorder. So, following Oregon's lead in decriminalizing drugs, and so on an individual level, supporting the decriminalization of drug use, the legalization of drug use, supporting greater and better access to substance use disorder treatment. We still have nowhere near the level of services that we need. And the vast majority of people with substance use disorder are not in treatment, never access treatment, don't have access to it. It needs to be effective and affordable and culturally competent and linguistically accessible. And we just don't have enough of it. So those are kind of two of the pieces. And then for San Francisco, a lot of it is also related to housing. People who are unhoused are using substances to survive on the streets, and we need to be housing. It serves as an overdose prevention effort. It serves as a health quality of life, economic justice. It's an everything issue. People who are unhoused need housing.
Yeah, I'm going to concur. I mean, Laura, thank you for bringing that up. That's a huge piece of it. That's a huge piece. So many of the clients that we see, their drug use has increased being on the streets. So we can't address it. There is such an intersection there as well in Los Angeles too. So thanks for mentioning that.
Well, again, the parallels around housing to HIV, right? We know in San Francisco, based on the epidemiology report, that the more stable housing you have, the more virally suppressed you are, the more you have access to meds, healthcare, like the housing, and in both of our cities, that we are in a crisis around being able to house folks. And so thanks for mentioning that. The other thing I'll mention is, Laura, what happened last night. So if there's a public hearing by your city or your neighborhood or that is around some of these issues, go and do some public comment and talk about your support for things like safe consumption sites. Or here, our city is going to try to open a meth sobering center in the neighborhood that I live in, South of Market. So there are ways that you can kind of show up and really talk about the data and the science that says that all these things are good things to have and actually decrease what people are concerned about. So there are lots of ways to get involved. Another question that has come in on Twitch is that the Biden administration changed some guidelines around prescribing buprenorphine, I don't know if I said that right, to treat opioid addiction this week. Will this have any impact on any of the programs at either of the agencies? Ro, why don't we start with you?
Yeah, it will. It's when we talk about barriers, right? This is breaking down one of those barriers so that more providers will be able to prescribe buprenorphine, and not just doctors, right? Like our nurse practitioners. And, you know, in the past, you know, a provider could only have so many prescriptions on their license. And so that in itself would be a barrier. You know, I could tell you like a story, like at the harm reduction center prior to COVID, having a nurse there, and, you know, there might be a great need that day. Maybe 10 people wanted to get on buprenorphine, but they only have 3 slots because they only have that many folks that they could take in onto their license. So something like this, you know, once this happens, that provider, for example, that day would have been able to see everybody and provide buprenorphine to everybody in the room that day that had wanted it.
And Ro, can you talk about what buprenorphine does? Like what is it? What are people coming in to access it for? Or Sarah, if you want to answer that.
I like to hear Ro.
Okay. Buprenorphine is it's opiate replacement therapy. It's a partial agonist, so it's gonna come in and replace the opiates that you've been using. So you're not, if it's done correctly, you're not going to experience really harsh withdrawals, and you'll be able to, you know, maintain yourself and not be dope sick and go about your business. You know, like looking at buprenorphine and looking at methadone, right? Folks might be really familiar with methadone. With methadone, it's also opiate replacement therapy, but someone has to go to a clinic every day, right? And that's a barrier. With buprenorphine, you get a prescription and, you know, you have more autonomy, and you would have maybe a week's worth of supply and be able to, you know, do that every day. And maybe that will make it easier for you to have a job or to normalize your life in some way. And I think that's an important distinction there. I welcome anyone else to jump in. That was a little choppy.
Sarah, Laura, anything from you two?
I mean, again, Ro, that's correct.
And just to say that the Biden administration has made some change to this, but more is still needed. Buprenorphine is unique in that it has required additional training in order to prescribe it. Doctors are able to prescribe all the other opioids, like, you know, opioids for pain management, but not this particular opioid for substance disorder treatment, for opioid use disorder treatment. And that's been an absurd barrier that's based entirely in sort of stigma and stereotypes about people who use drugs, that there's no reason, there's never been any clinical or medical reason for it to be as complicated to prescribe as it is. So this is one step, and it makes it a little bit easier. It removes the training requirement. You can now prescribe up to 30 patients, but as Rose said, there's a cap on how many patients you can prescribe to, and that's just the ridiculous restrictions. So a lot of people are pushing pretty hard on the Biden administration to fully remove this X waiver, as it's called, and I'm confident that the administration is going to, and this is a very good step.
I know some of the arguments that we hear from opponents of things like safe consumption sites or syringe access or needle exchange, you know, are these arguments that were somehow our activity is enabling behavior and it's not getting people into treatment, even though really the opposite is really what is true. So what are the messages that we need to tell folks who, like, for instance, if I'm on doing TogetheRide and I'm at Raising Money and I'm talking about this work, what are some of the points or the myths that I can bust for people about some of the work that we've been talking about today? Sarah, why don't we start with you?
Sure. Well, I think those myths are started by people that don't have a lot of experience in these services. I think that it's just perpetuated by incorrect information. And so, yeah, I mean, there's study after study that shows that harm reduction actually decreases overdoses. It actually, and then you could just follow that line. A decrease in overdoses is a decrease in hospitalizations and the stress that it puts on the healthcare. Yeah, there's a trickle down, I guess, is what I'm trying to say. And I think that what I would say to someone is to do a little bit more of the research and to pay a little more attention. I think that those things are steeped in the same stigma and the idea that people don't have a right to choose how they take care of themselves. And it's sort of an issue of control and other people trying to control how people take care of themselves. So yeah, I think there's a lot of personal bias and stigma that contribute to it. But it's just inaccurate. There's study after study being done showing that it's inaccurate.
Yeah, I think a lot of us got really. What? I think a lot of us got really bad drug education when we were in school. I think a lot of us were really misinformed, and continue to be misinformed by, popular TV shows that misrepresent drug use, that misrepresent people who use drugs. And it's challenging. I think it's one of the biggest challenges that I face in doing my job and talking to policymakers and elected officials is that they've heard these myths and these misconceptions and these stereotypes. They've watched intervention on TV or and the reality is much more nuanced. There are a million different reasons why people use drugs. There are different reasons why people develop problems related to drugs. There are different pathways for people to stop, to change their relationship with the substances that they use. And it's never as easy as just say no. It's never as easy as hitting bottom. Enabling isn't really a thing. But it can be hard to discern and understand what is real and what isn't when we're surrounded by a world that's giving us bad messages and telling us that people who use drugs are bad and immoral or sinful or diseased. It becomes hard to push back on that. So yeah, I would encourage people to dig into it a little bit more, find reliable sources and listen to them.
What about you, Ro?
I think too, for folks to really lean into what like radical compassion and care means, and just really just breaking it down even further. When you isolate folks, you can't really I guess what I'm trying to say is, within harm reduction, right? Like, as long as you're building relationships with somebody, they're going to keep coming back. That trust is going to get built. And, when they are ready, if they are ready for something more, then you're there for them. But I think it's all about that piece around trust and connection, and that somewhere gets lost along the way. And I think there's just sometimes misplaced anger in our society when we when folks see this extreme, economic disparity and folks suffering, and there's just no space for it, and folks will get angry, or someone will internalize what worked for them and think it's going to work for everyone, and not realize all the ways that it might not work for someone else. And so just something around the open-mindedness and compassion, and really building connection, that somewhere along the way gets lost, and people get really very single-minded around it and think it's one or the other, and it just can't be that way.
Laura, one of the things that so amazing, all three of you, that I like, all these thoughts are like pouring into my head. I just had a conversation with a friend a few weeks ago who was being very stigmatizing about folks who are living on the street and using drugs. And I turned to him and I said, well, how is it any different? Is it because you live in $1 million apartment and you do drugs that somehow you are you are like, what's, I don't understand what you're trying to get at here. Like, because you're pointing the finger when you yourself are, it's that kind of, I think, well, that's not me. Like, just the stuff that we've been talking about today and unpacking that, I think, is really important for folks to listen to and to understand. But one of the things, Laura, we talked about in the call was, that's mentioned in the video, is the war on drugs and its terrible impacts on our communities. And one of the things you mentioned was related to the George Floyd trial, because when we did the prep call, there had not yet been a decision. And the defense talked a lot about drug use and fentanyl, and really tried to put out there all of these terrible myths about George Floyd and about folks who use drugs. So could you talk a little bit about that, around connecting those dots a little bit around the trial, the war on drugs, and why we need to unlearn, as you were talking about earlier, the things that we've learned about drug use in the United States?
Yeah, and the war on drugs has roots, and they're very racist roots. So the reason why some drugs are legal and others are not legal in this country is really just about racism and structural racism and systems of racial control. Here in San Francisco, we passed some of the first laws criminalizing substance use, and it was targeting the Chinese community and opium smoking. And it's gone on from there in terms of, marijuana is illegal because of racist concerns about Mexican migrant workers, and, cocaine with this concern about African Americans, and, the horrors of jazz musicians. And, none of it was because these are dangerous substances. It was all because these are dangerous people, or people that we want to control. And that has continued. I mean, I think the stuff that came up in George Floyd's trial, trying to say that he had superhuman strength because he was on drugs, that's a very specific and very deeply seated racist trope that, goes back decades and decades of saying that Black men in particular were more dangerous because of their drug use. And I think it's up to, I think I'm going to assume that we were all horrified by that video of George Floyd being murdered, by Breonna Taylor's murder, for example. Eric Garner, these are all people who were killed in part by the war on drugs. And the war on drugs created the situation in which an individual police officer then murdered these people. And so it's part of undoing the racial disparities in this country, of undoing white supremacy, of uprooting all of this, involves uprooting the war on drugs and uprooting prohibition. So, it's sort of blaming George Floyd's drug use on his death when the very obvious cause of his death was this police officer kneeling on his neck for 9 minutes. It's horrifying that those types of arguments continue to get any traction in this country. And I think, regardless of whether we identify as someone who uses drugs or not, I think we can all still see the ways in which we need to undo these policies and undo these laws and undo this kind of stigmatization and the racism that underlies a lot of this. So I'm not sure if that answered your question, Russell, but that was what I had on my mind about this.
No, that is exactly. I mean, it's something that we had talked about before, and that there was so much energy around it, and I didn't want to, as our time comes to an end, I did not want that to not be said, because I think that is really important to understand what we're dealing with now, and really the legacy of something like that, and how all of us have a responsibility in trying to undo the war on drugs, because it's really just hurting the communities that we operate in and that we care about. And so I want to thank all of you. Thank you, Sarah. Thank you, Laura. Thank you, Ro, for joining us for this edition of TogetheRide In Conversation. There is so much more that we could unpack and talk about, but we'll save that for another time. So thanks for joining us. And again, you are supporting all of this amazing work, both at the Los Angeles LGBT Center and the San Francisco AIDS Foundation, through your support of TogetheRide. So a couple of closing announcements. I want to thank all of our TogetheRide participants and donors. We are so close to raising $1.5 million. Great job, everyone. If you want to donate or join TogetheRide on our journey to raising $5 million for Los Angeles LGBT Center and San Francisco AIDS Foundation for HIV/AIDS services, please visit TogetheRide.org. It's not too late to sign up, to get your friends, family to sign up. So again, go to TogetheRide.org. And as of this weekend, we will be 60 days out from the end of TogetheRide 2021, and we are challenging you to ride 60 miles or ride, run, jump, skip, roll, whatever suits you for 60 minutes in celebration, and ask your friends to donate $1 for every mile or minute you complete. We know you can do it. So again, on behalf of all of us at San Francisco AIDS Foundation, Los Angeles LGBT Center, and TogetheRide, thank you for joining us for this edition of In Conversation. I'm Russell Roybal, and we will see you again very soon. Have a great rest of your day.